Welcome to the deep dive. Today we're embarking on a really crucial journey, I think, into the intricate world of joint pathologies.
Yeah, it's a big topic.
It really is. Imagine your joints as these incredibly complex, almost perfectly synchronized machines. But what happens when, these machines start to wear down? Or they get attacked by their own system, or even become like battlegrounds for unwelcome invaders.
Hmm.
So, our mission today is to equip you, our curious listener, especially those of you just starting your medical journey with that core knowledge, to understand, differentiate, and, well, begin to approach the most common and critical joint conditions.
Right.
We'll be extracting the essential nuggets from our source material on osteoarthritis, rheumatoid arthritis, gout, and septic arthritis. And we'll touch on spondyloarthropathies too.
Good plan.
And as you step into the clinic, you might wonder, how do we really tell the difference between a joint that's just, well, worn out from years of use and one that's actually under an internal attack? I'll definitely get into that.
Yeah, that's a fantastic question to kind of anchor us. What's truly fascinating, I find, is how distinct each of these conditions can be, even though, they all affect our joints.
Exact.
Understanding the why behind the what is absolutely key, not just to grasping the pathologies, but maybe more importantly, to retaining this information effectively as future healer.
Right. Makes sense.
So yeah, we'll be highlighting the unique pathophysiology, the presentation, key investigations, and management principles for each one, offering you clear differentiators and hopefully some memorable anchors you can carry into your practice.
Perfect. Okay, before we dive into the diseases themselves, maybe a super quick refresher on our synovial joints' essential structures,
Yeah,
because these are the main players in our joint drama.
good idea. The basics are key.
So we're talking about the joint capsule, right? That fibrous outer membrane, the inner synovial membrane, and the synovial fluid itself, that's like the joint's lubricant.
The oil in the machine.
Exactly. Then there's the crucial hyaline cartilage, that smooth, slippery surface covering the ends of the bones, plus supporting structures like ligaments, those shock-absorbing menisci in the knee, and bursae, those little fluid-filled sacs that reduce friction.
Yeah, all vital components. Knowing these helps picture where things go wrong.
Okay, so let's unpack this first one. Osteoarthritis, OA. It's often called the wear and tear disease, and, well, that's a useful starting point, maybe, but it's actually a much more complex interplay.
It really is.
We're now seeing it less as just passive damage and more as like a dynamic process involving low-grade inflammation and changes throughout the entire joint. So what's truly happening at a fundamental level in an OA joint?
That's a great question because wear and tear, while common, doesn't quite capture the full picture. OA is actually a disease of the entire joint, fundamentally characterized by the gradual loss of that smooth articular cartilage we just mentioned.
Right, the slippery surface.
Exactly. But it's not just the cartilage. The underlying bone changes too, it reacts, and even the synovial membrane can show signs of inflammation. It's really an interplay between individual risk factors, mechanical stress, and sometimes abnormal joint mechanics. And we generally differentiate between primary OA, where we don't have an obvious underlying cause, it's kind of idiopathic, and secondary OA, which is due to some pre-existing abnormality like previous trauma or developmental issue like hip dysplasia.
Okay, and this isn't some rare condition, is it? Who are we typically seeing walk through the door with OA?
Not at all. It's incredibly prevalent. I mean, we're talking about 10 million people affected in the UK alone, for instance. Millions experiencing knee or hip OA specifically. And the median age for symptoms starting is around 55.
Oh, okay.
As for risk factors, some are non-modifiable, things you can't change.
Mm-hmm.
Age, especially being over 45, being female, genetics play a role, and joint malalignment, like developmental dysplasia of the hip, DDH. But then we have the crucial modifiable risk factors. Things like obesity, which puts extra load on the joints, excessive occupational stress, or certain types of exercise, and importantly, muscular weakness around the joint.
Ah, so things we can actually do something about.
Precisely. Those modifiable factors highlight areas where we and the patient can make a real difference.
So let's picture this. Imagine a 65-year-old retired carpenter, let's call him John. He comes to your clinic. He tells you his knees have been getting progressively ickier, especially after a long walk or climbing stairs. This kind of insidious activity-related joint pain sounds pretty classic for OA, right? What are you listening for in his story, and what will you look for when you examine him?
Absolutely. His story gives us key clues. With OA, the pain often gets worse with activity and, importantly, improves with rest.
Okay.
And crucially, think back to your intro question, there's usually no morning stiffness. Or if there is, it's very brief, lasting less than 30 minutes. That's a vital clue to differentiate it later.
Got it. Less than 30 minutes.
Right. Then, on examination, when you look, you might see some swelling or maybe some bony deformities. We have classic names for these on the fingers, Bouchard's nodes on the middle joints, Heberden's nodes on the joints closest to the nail.
Okay.
When you feel the joint, it might be a bit warm, maybe tender. You might actually feel those bony protrusions, the osteophytes we'll mention later. And then when you move it, you'll often hear or feel crepitus, that grating sensation. It really does feel like sand in the gears of the joint. And the range of motion will likely be restricted and painful.
Okay, that crepitus sounds quite distinctive. So if we suspect OA, how do we confirm it, especially for someone just starting out? What's the essential imaging we should know?
Yeah, often the diagnosis is clinical, based on that typical history and the examination findings we just discussed.
Right.
But if you have atypical features or you need to rule something else out, then an X-ray is key. And for remembering the signs of OA on X-ray, there's a really useful acronym, LSS.
LS. Okay, what does that stand for?
So L is for loss of joint space. That gap between the bones narrows because the cartilage has thinned.
Okay.
O is for osteophytes. Those are the bony overgrowths, the spurs you can sometimes see and even feel.
Right, the bony protrusions.
Exactly. S is for subchondral sclerosis. That means the bone just beneath the cartilage has become denser, it's thickened up. And the final S can stand for subchondral cysts. There's a little fluid-filled sacs within the bone near the joint surface. But honestly, for quick initial confirmation, you're mainly looking for that joint space narrowing and the osteophytes.
LOSS. Okay, that's a great anchor. Loss of joint space, osteophytes, subchondral sclerosis, subchondral cysts. Got it. And once we've identified OA, what are the first steps in managing it for our carpenter, John?
Right. Well, the NICE guidelines give us a really clear map here. The first line, what they call core treatment, is all about education, helping John understand his condition, what to expect. This is paired with therapeutic exercise, especially strengthening the muscles around the affected joint that provide support. And, if appropriate for the patient, weight loss is huge, especially for knee and hip OA.
So education, exercise, weight loss, the fundamentals.
Absolutely fundamental. Then as adjuncts, things we add on, we might consider NSAIDs, that's non-steroidal anti-inflammatory drugs, usually with a PPI, a proton pump inhibitor, to protect the stomach lining. Topical NSAIDs, creams, or gels are often preferred as they have fewer systemic side effects.
Okay.
Interestingly, the evidence for paracetamol isn't very strong anymore for OA pain.
Oh, that's good to know.
Yeah. If those conservative measures aren't enough, we might explore corticosteroid injections into the joint, mainly to reduce pain enough to allow them to engage with the exercises.
That's a bridge.
Exactly. And then, as a sort of last resort, when quality of life is really severely impacted, surgical options like joint replacement come into play. But crucially, a multidisciplinary team approach is vital throughout. Physiotherapists, occupational therapists, they play a massive role in managing OA.
Okay, that makes a lot of sense. Now, let's shift gears dramatically, because here's where it gets really interesting, I think. If OA is the wear and tear, maybe like an old machine grinding down, rheumatoid arthritis, RA, is a very different beast altogether.
Completely different, yes.
This isn't about natural wear. This is a chronic, systemic, inflammatory disease, an autoimmune condition where your body mistakenly attacks itself. Can you paint us a picture of this internal attack? What's going on there?
Absolutely. Think of it like your body's internal security system has gone rogue, gone haywire. Instead of protecting you from invaders, it's mistakenly targeting the synovial membrane, that lining inside your joints.
Ah, the lining itself.
Yes. We think external triggers, maybe an infection or something else in genetically susceptible people, essentially flip a switch. This leads to the production of autoantibodies, antibodies against your own tissues. That triggers inflammation, causing the synovium to thicken and swell. We call that synovitis. And over time, this inflammation can erode cartilage, bone, ligaments, eventually leading to joint destruction and deformity if it's not controlled.
Wow.
And critically, remember, it's a systemic disease. It doesn't just hit the joints. It can affect the eyes, the lungs, the cardiovascular system, even mental health. Plus, it can lead to other problems like osteoporosis and anemia of chronic disease. It's a whole body issue.
Right. Systemic is the key word there. So who typically gets RA, and what are the main risk factors we should be aware of?
Well, RA affects about 1% of the population, so it's reasonably common. While it can technically occur at any age, it typically presents between 30 and 50 years old. Although, interestingly, there's another peak in incidence later in life in the 70s. Key risk factors include having a family history of RA. There's a significant female-to-male ratio, about 3 women for every 1 man affected. And smoking is a major environmental risk factor.
Smoking. Interesting. Okay, so let's consider a patient, maybe a 40-year-old woman who comes in, and we suspect RA. What's her story likely to sound like, and what are we going to see when we examine her? Especially thinking about how to distinguish it from OA.
Okay, her history will often point towards inflammatory arthritis,
Hmm.
typically affecting the small joints of the hands and feet, think knuckles, wrists, balls of the feet, and usually in a symmetrical pattern, meaning both sides are affected similarly.
Symmetrical, okay.
She'll describe pain, swelling, and stiffness in these joints. Most commonly, you'll see involvement of the MCP joints, those are your main knuckle joints, and maybe the PIP joints, the middle finger joints, and the wrists.
Right.
Now here's a critical differentiator from OA. Her symptoms are often better with activity and worse with rest. She might feel awful when she first gets up, but moving around helps ease the stiffness.
Ah, the opposite of OA in that sense.
Exactly. And to answer our earlier question directly, the stiffness is characteristically worse in the morning and persists for more than 1 hour after waking up, sometimes several hours. That prolonged morning stiffness is a real classic essential clue for RA.
Got it. More than an hour morning stiffness, think RA. Less than 30 minutes, think OA.
That's a great simplified anchor. On examination, when you look, you'll see swelling, often described as boggy swelling of the joints. Over time, you might see those characteristic deformities like ulnar deviation, where the fingers drift towards the little finger side, or swan neck, and boutonniere's deformities in the fingers. The joints will be warm and tender when you feel them, and movement will show stiffness and a reduced range of motion. A useful test is the MCP squeeze test, gently squeezing across the knuckles, which will often be painful in RA.
Okay, so lots to look for. What are the key investigations we'd order if we suspect RA?
Right, and investigations are crucial here. Blood tests are essential. We look for specific autoantibodies. Anticyclic citrullonated peptide antibodies, usually shortened to anti-CCP, which is quite specific for RA.
Anti-CCP.
And rheumatoid factor, or RF, though RF can be positive in other conditions too. We also check inflammatory markers like ESR and CRP, which will typically be raised. And a full blood count, FBC, might show anemia.
Okay, and imaging.
Imaging often starts with an X-ray of the hands and feet. Early on, it might just show soft tissue swelling. But key signs to look for are joint space narrowing, similar to OA, but often more uniform, and critically marginal erosions. These are little bites taken out of the bone right at the edge of the joint. Ultrasound can also be very useful, especially early on, to detect synovitis.
Marginal erosion's another key visual. Okay. And how do we approach management for a new RA diagnosis? What's the goal here?
The absolute goal is aggressive early intervention to prevent that irreversible joint damage we talked about. The mantra is treat to target, aiming for remission or low disease activity.
Okay, early and aggressive.
Yes. So in primary care, the main thing is prompt referral to rheumatology. Get them seen quickly. In secondary care, the first-line treatment is typically oral methotrexate. This is a disease-modifying anti-rheumatic drug, a DMARD. Right. These drugs actually work to slow the progression of the disease itself, not just treat the symptoms. They're often started alongside corticosteroids, maybe as a short bridging therapy, to quickly control the inflammation while the DMARD starts working, which can take a few weeks.
Makes sense.
If conventional DMARDs, like methotrexate, aren't effective enough or aren't tolerated, then second-line treatments usually involve biologic DMARDs or targeted synthetic DMARDs. These are more advanced therapies targeting specific parts of the immune response.
Okay.
Surgical referral might be needed in specific situations, like for an acute tendon rupture, or sometimes later on to correct deformities or replace severely damaged joints.
Yeah.
And again, that multidisciplinary team is crucial. Hand therapists, podiatrists, specialist nurses, physiotherapists, they all help manage the broader aspects of the condition and maintain function.
Right, the whole system approach again. Okay, let's switch gears dramatically now. Imagine tiny, sharp crystals forming a really painful party inside your joint. This, in a nutshell, is gout. What's causing this crystal storm?
Crystal storm is a good way to put it. Gout is an acute, often incredibly painful inflammation that results from monosodium urate crystals precipitating, basically forming, within a joint.
Monosodium urate. Okay.
Right. Urate is a normal purine metabolite. It's a byproduct of breaking down purines found in our diet and in our own cells. But when levels of urate in the blood get too high, what we call hyperuricemia, these crystals can form in joints and other tissues.
I see.
And it's important to remember, while gout involves these monosodium urate crystals, there's another condition called pseudogout, which has a very similar presentation, red, hot, swollen joint, but it's caused by calcium pyrophosphate crystals. Different crystal, different underlying cause, but similar acute picture sometimes.
Ah, okay. Gout versus pseudo-gout depends on the crystal. Good distinction. So who is most susceptible to this crystal storm of gout, and what are some risk factors?
Gout is actually the most common type of inflammatory arthritis. It typically affects men over 30 and postmenopausal women. There's a higher prevalence in certain populations, interestingly.
Mm-hmm.
Key risk factors include having a family history of high urate levels or gout itself.
Mm-hmm.
Other health conditions are big ones. Chronic kidney disease, diabetes, hypertension, and significantly, lifestyle factors play a huge role, especially a high purine diet.
High purine diet.
Yeah.
What does that mean practically?
That means things like excessive alcohol intake, particularly beer and spirits.
Mm-hmm.
Also, lots of red meat, organ meats like liver, and certain types of seafood, especially shellfish. These can all raise urate levels and trigger attacks in susceptible people.
Right. Beer, red meat, seafood.
Yeah.
Yeah.
Obesity is another major factor. Certain genetics play a part, and even some common medications can contribute, like certain diuretics, water pills, or low-dose aspirin.
Okay, quite a few triggers there. So our patient comes in. What's their typical story for a gout attack? How does it usually present?
They'll often describe a really acute onset of severe pain, frequently waking them from sleep overnight. It comes on fast and furious.
Overnight onset, okay.
It's typically in a single joint, which becomes incredibly red, hot, swollen, and exquisitely tender. People often say even the weight of a bed sheet on the affected joint is unbearable.
Wow.
In about half of all first attacks, it affects the first metatarsophalangeal joint, or MTP joint. That's the joint at the base of the big toe. We sometimes call this podagra.
The big toe joint. Classic.
Very classic. Although other joints like the ankle, knee, wrist, or fingers can be affected too.
Oh.
And over time, if gout isn't well managed, some patients can develop tophi.
Tophi, what are those?
Tophi are these hard, chalky-looking nodules under the skin. They're basically deposits of sodium urate crystals. You often see them on the extensor surfaces like elbows or over affected joints, on the Achilles tendons, or even on the outer rim of the ear.
Okay, visible crystal deposits. Got it. So how do we definitively confirm a diagnosis of gout, especially differentiating it from, say, pseudo-gout or even infection? What's the crucial investigation?
Right, good question. While blood tests might show an elevated blood urate level, that's not definitive. Levels can actually be normal or even low during an acute attack sometimes.
Oh, okay.
The truly crucial gold standard diagnostic step is joint aspiration. You take a needle, carefully draw some synovial fluid out of the inflamed joint,
Right, aspirate the fluid.
and then you look at it under a special type of microscope using polarized light.
Uh-huh.
For gout, you're looking for needle-shaped, negatively birefringent urate crystals. They often look like tiny, bright needles.
Needle-shaped, negatively birefringent. Okay, that's the key visual for gout.
Exactly. And for pseudogout, just for comparison, you'd see rhomboid-shaped, positively birefringent calcium pyrophosphate crystals. So the crystal shape and how they bend light tells you which one it is.
Perfect. Crystal analysis is key.
It really is. And a really critical warning here, similar to what we'll say for septic arthritis.
Yeah.
Do not attempt to aspirate a prosthetic joint yourself in primary care or the emergency department.
Mm-hmm.
If you suspect gout or infection in an artificial joint, that needs urgent referral to orthopedics.
Right. Prosthetic joints, hands-off, refer. Very important. So what's the essential management for both an acute gout flare and then preventing future attacks?
Okay, for an acute flare, the first step is always to rule out red flags suggesting infection, like high fever or severe systemic illness. If it looks like typical gout, the primary treatments are aimed at reducing that intense inflammation quickly.
Okay.
Options include high-dose NSAIDs, like naproxen, usually given with a PPI for stomach protection, or a medication called colchicine, which specifically targets gout inflammation, or sometimes oral corticosteroids like prednisolone.
Right. Cool the inflammation down fast.
Exactly. And patient education about diet modification and avoiding triggers is also crucial during and after an attack. For prevention, especially in patients who have recurrent flares or tophi or joint damage, we use medications to lower the urate levels in the blood long term.
Okay. Prevention meds?
The main one is allopurinol. It works by reducing the body's production of uric acid. It's usually started a few weeks after an acute flare has completely settled down, not during the flare itself. And it's often a lifelong treatment, aiming to keep the blood urate level below a specific target, usually less than 360 micromole per liter, to prevent crystals forming.
Allopurinol for long-term prevention. Got it. Okay, now, let's talk about the absolute joint emergency. Septic arthritis. You mentioned infection, and this is it. This is when infection invades the joint and it is a race against time. If a joint could scream, this one would be screaming. Why is this condition such a critical emergency?
It's a critical emergency, you're absolutely right, because the infection causes joint inflammation that can lead to irreversible destruction of the joint cartilage within as little as 6 hours.
6 hours.
Yeah, 6 hours. The bacteria or other organisms release enzymes, proteases, that literally dissolve the cartilage. And the body's own intense inflammatory response to the infection also contributes significantly to that damage. So it is absolutely a time is joint scenario.
Time is joint. That's a powerful anchor.
It really is. And sadly, the mortality rate is not insignificant either. It's around 10%. The specific infectious organisms can vary a bit by age group, but overall, Staphylococcus aureus is a very common culprit in adults. Infection can get into the joint either through the bloodstream hematogenous spread or by direct inoculation, like after a puncture wound, surgery, or even an injection into the joint.
Okay, so high stakes, rapid damage. Who is at highest risk for getting septic arthritis, and what are their typical symptoms?
It's actually more common in children than adults, often affecting the hip. But in adults, risk factors include being immunocompromised, having a weakened immune system, having other underlying joint problems like rheumatoid arthritis or even osteoarthritis. Also, conditions like diabetes, having skin infections elsewhere, and importantly, a history of recent joint surgery. Any kind of intra-articular injection or the presence of a prosthetic joint, that's a huge risk factor.
Right, the prosthetic joint again.
Exactly. Presentation-wise, a patient will typically present with an acute onset of symptoms, usually affecting just one joint monoarticular. The knee is the most common site in adults, the hip in children.
Okay.
They'll complain of pain, plus meaning really severe, intense pain. The joint will be noticeably swollen, red, and warm to the touch. And crucially, unlike some other conditions, they'll often have systemic symptoms: fever, chills or rigors, muscle aches, myalgia, and just feeling generally unwell, malaise.
So joint symptoms plus systemic illness, that's a red flag.
Big red flag. Fever and a single hot, swollen, painful joint should scream septic arthritis until proven otherwise.
Okay, and when you examine them, what are you looking for, and what is the absolute most critical investigation?
Right, on examination, you'll see that red, swollen joint. The patient will likely have an antalgic gait, meaning they're limping badly to avoid pain, or they might be completely reluctant to put any weight on that limb at all. It will be obviously warm and very, very tender when you feel it. And movement will be significantly reduced and incredibly painful. Often they hold the joint very still. You'll also likely find those systemic signs we mentioned: fever, maybe a fast heart rate, tachycardia.
Okay.
The most critical investigation, without a doubt, is immediate joint aspiration. Just like for suspected gout, but here, the urgency is even higher.
Get that fluid out fast.
Immediately.
Yeah.
You need to look at the fluid. Typically, it's cloudy or purulent, like pus. You send it urgently for a gram stain to look for bacteria under the microscope. Check the white cell count, which will be very high. And crucially, send it for culture and sensitivity, MCS, to identify the specific organism and know which antibiotics will kill it. Crystal analysis should also be done to rule out gout, pseudogout. And again, that vital warning: do not aspirate a prosthetic joint yourself. That requires immediate orthopedic involvement for washout surgery. Always get blood cultures too, as the infection might be in the bloodstream.
Got it. Aspirate native joints urgently. Check fluid, send for MCS. Refer prosthetic joints. So, given this extreme urgency, how is septic arthritis managed?
Management is an absolute emergency room or hospital-based process. It requires immediate admission and starting empiric intravenous antibiotics, meaning you start broad-spectrum antibiotics right away before you even know the exact bug, often a combination like flucloxacillin plus gentamicin, covering the most likely organisms.
Start treating immediately.
Yes, don't wait for culture results to start treatment. Then, once the culture results come back in a day or two, you review and adjust the antibiotics to target the specific organism found. Often, surgical washout of the joint is also needed to physically remove the infected material. Rapid, decisive action is absolutely paramount to save the joint and, honestly, potentially, the patient's life. Okay, so we've covered the big four in detail, but just briefly, moving beyond those, we should mention a group of conditions known as the Spondyloarthropathies.
Spondyloarthropathies.
It's a bit of a mouthful. This is basically a family of related chronic inflammatory rheumatologic conditions. What links them is that they primarily affect the axial skeleton, so that's the spine and the sacroiliac joints, and also the entheses.
Entheses, what are those?
Entheses are the points where tendons and ligaments attach to bone. Inflammation there is called enthesitis, and it's quite characteristic of this group.
Ah, okay. Spine and attachment points. And what conditions are in this family?
The main ones include ankylosing spondylitis, which we'll touch on more. Then there's reactive arthritis, psoriatic arthritis, and arthritis associated with inflammatory bowel disease like Crohn's or ulcerative colitis. And sometimes we see undifferentiated spondyloarthritis where it doesn't fit neatly into one box.
Okay, quite a group. Let's maybe focus just a bit more on ankylosing spondylitis, AS, as it's a relatively common one in this group. What are its defining features?
Right. Ankylosing spondylitis, or AS, is a chronic inflammatory disorder that primarily affects the axial skeleton, especially the sacroiliac, or SI, joints at the base of the spine and the spine itself.
Okay.
It often presents in young adults, typically under the age of 45, with a peak incidence usually between 20 and 30 years old, so younger than OA or typical RA onset often.
Right, young adults.
There's very strong genetic linkage. About 90% of patients with AS carry a specific gene marker called HLA-B27. And historically, it was thought to affect men much more often than women, though we now recognize it affects women too, perhaps sometimes with different patterns.
HLA-B27. Okay, strong genetic link. So how would a patient with AS typically describe their pain? How does it differ from, say, simple back pain or OA?
Good question. They'll usually describe insidious onset pain, meaning it creeps up slowly. It's often felt deep in the lower back or buttock region, and it's typically lasted for more than 3 months. A key feature is that it often wakes them from sleep, particularly in the second half of the night.
Wakes them from sleep. Okay.
And here's another crucial differentiator. Unlike mechanical back pain or OA, the pain and stiffness in AS are typically better with exercise and movement, but worse with rest. Especially worse first thing in the morning or after sitting for a while.
Ah, inflammatory pattern again, like RA, but in the spine. Better with movement.
Exactly. That inflammatory pattern is key. Over time, this inflammation can lead to fusion of the spine, causing a significant loss of spinal mobility and changes in posture, often a stooped posture. On X-ray of the SI joints and spine, you can see characteristic changes like sacroilitis. And in advanced cases, the spine can fuse into what's classically described as a bamboo spine.
Bamboo spine. Wow, that's a powerful visual anchor for spinal fusion.
It really is. Management for AS involves things like NSAIDs for pain and stiffness,
Yeah.
specialized biologic drugs called anti-TNF agents, which can slow disease progression, and absolutely crucial is ongoing physical therapy and exercise to maintain mobility and posture.
Right, physiotherapy is key again.
Always key in these inflammatory conditions.
Yeah.
And just to briefly touch on a couple of the others in that spondyloarthropathy group, psoriatic arthritis is an inflammatory arthritis seen in people who also have the skin condition psoriasis. It has various patterns, but can often affect the joints at the ends of the fingers and toes, the DIP joints, sometimes asymmetrically, and can also involve the spine. On X-ray, you might see a characteristic pencil and cup deformity, where one bone end erodes into a cup shape in the adjacent bone.
Pencil and cup. Another visual.
Yeah. And then there's reactive arthritis, which is basically an acute arthritis that develops after an infection elsewhere in the body, often a gastrointestinal infection or a sexually transmitted infection like chlamydia. The classic triad used to be can't see, can't pee, can't climb a tree, referring to conjunctivitis, urethritis, and arthritis, though not everyone gets all three.
Okay, so arthritis reacting to an infection elsewhere.
Got it.
Got it. That really broadens the picture beyond just OA and RA.
Definitely. It shows the variety of ways joints can become inflamed.
Okay, wow. We have covered a lot of ground today. From the wear and tear of osteoarthritis, which we learned isn't just wear and tear all the way to the autoimmune attack of rheumatoid arthritis, the crystal storm of gout, and the critical time-sensitive nature of septic arthritis, and a glimpse into the spondyloarthropathies, too.
Yeah, quite a tour.
Absolutely. And hopefully you've picked up on those key differentiators we discussed. Remember, OA's minimal morning stiffness, less than 30 minutes, versus RA's prolonged morning stiffness, more than an hour. Remember the sharp needle crystals under polarized light for gout? And remember that urgent 6-hour window for septic arthritis where irreversible joint damage can happen times joint.
Those are great anchors.
They really help, I think, as you approach these cases in the clinic, helping you answer that crucial question we started with. Is this joint just worn out, or is it actually under attack?
And thinking about all this raises an important, maybe slightly broader question for you, our listener, to ponder. Given these varied presentations, and especially the systemic nature of conditions like RA or the lifestyle links with gout, how might a patient's overall lifestyle, beyond just exercise and diet, maybe think about stress levels, sleep patterns, even their social environment, how might all that impact the progression and management of these conditions that seem on the surface to be just localized joint issues?
That's a great thought. The interconnectedness of everything.
Exactly. How does the whole system influence joint health? Something to think about.
Definitely something to chew on. So, what stands out to you from this deep dive? Keep those questions churning. We really hope this has given you a solid, practical foundation as you continue your journey into understanding the amazing and sometimes troublesome human body.
Keep curious.
Until next time, keep learning, keep exploring, and keep those joints healthy.